today are my wonderful colleagues, Kayla Mead and Jenna Lennon. So I am actually a care partner from afar to my own brother, who was diagnosed with Parkinson's in 2011. And I recognize how important community and resources are to loved ones of people with Parkinson's. So I just want to extend a heartfelt thank you to all of the care partners joining us here today, both in person and online. We have a few hundred people joining us online today, so welcome to everyone. I want to start by extending a huge thank you to our national presenting sponsor, Acadia. I'd like to extend a sincere thanks to them for their tremendous support of this important topic, and we invite you to learn more about them here at the table today in person or online at the link that we will share in the chat. Many thanks as well to our local program sponsors, Platinum sponsor Kiowa Kirin, Gold sponsors AbbVie and Boston Scientific, and Bronze sponsor Accorda. And of course, you can learn more about them here today, or we are going to also send a link in the chat. A little bit about the Parkinson's Foundation. Our mission is to make lives better for people living with Parkinson's today until there's a tomorrow without the disease. And we do this through what we call our 3 pillars. So that is better care, research, and education and advocacy. Some of you may have seen these resources. We provide free resources, including our website, which is parkinson.org, our educational book series. We have webinars, podcasts, and a hospital safety kit called Aware and Care, as well as our newly diagnosed materials and our toll-free helpline, which is wonderful, at 1-800-4PD-INFO. The Foundation's newest research project is called PD Generation, and it is a no-cost at-home genetics test for people with a confirmed Parkinson's diagnosis. And the website for that is parkinson.org/PDGeneration. Also, right now, we're a partner in a research project called TOPAZ, and that studies bone fracture prevention in people with Parkinson's. And you can call us at that helpline number if you'd like more information about that study, Okay, we hope you will stay connected to us on our website, our social media channels, and by phone and email through our helpline. We have fun events coming up in Portland, also just to share, and all over the nation on February 25th. Our stationary cycling event is called Parkinson's Revolution, and it brings the community together for fun and fundraising for our important mission work. We invite you to learn more at parkinson.org/revolution or at the table with Jenna. Okay, a few housekeeping items. We encourage you to submit your questions at any point throughout the program. So you can either write your questions down on the index cards that are on your table, or online, we have both a Q&A and a chat function. We'll have a moderated Q&A segment with the speakers after the presentations. And we also want to let everyone know that we are recording the webinar portion, and we will post that on YouTube and share that video after the event. So we have a really wonderful program lined up for you today. We're going to talk about cognitive changes in Parkinson's and also navigating caregiver roles as they change and evolve. This program will not contain a Parkinson's basics or overview, but we have lots of videos on our YouTube channel. And if you'd like to learn more about Parkinson's, we invite you to visit the YouTube channel. Okay, and now I am happy to introduce our first guest speaker today. Dr. Lee Neilson is a board-certified neurologist specializing in movement disorders with an emphasis on Parkinson's disease at the Portland VA Parkinson's Disease Research Education and Clinical Center, also called a PADRECC, and Oregon Health and Science University, which is a Parkinson's Foundation Center of Excellence. Welcome, Dr. Neilson.
All right, well, thank you, Sarah. Thank you, everyone, for being here. As she said, I'm Lee Neilson, a neurologist. I'm delighted to be here today to talk about cognition. I have no disclosures. And the objectives today are fourfold here. So one, try to define some terms. So what is dementia? What is mild cognitive impairment? The next thing is to talk about what is the spectrum of thinking changes that can happen in Parkinson's and what might we expect over time. The next thing is going to kind of break down the brain into different domains of cognition. And then to illustrate what exactly those different functions are, we'll do some testing of that, what you might see in our offices. And then the last 2 points are what sorts of strategies are there, whether those are medication or other healthcare services or lifestyle interventions that we can use to try to support our thinking and memory throughout the duration of the disease. So I like to start most things with this slide to give everyone this sense of what is Parkinson's. The tip of the iceberg is what we see and is still how we diagnose the disease, but everything below, which is quite numerous, are probably even more important than the tremor and the stiffness. And we're going to be just focusing on this important part here, the cognitive issues. So what is the spectrum of cognition? So most people, when they're diagnosed with Parkinson's, do fall into that normal cognition range. This is something that you've been dealing with, that hopefully you've had for most of your lives. The brain does start to change at the age of 20. It starts to shrink at the age of 20, and it does start to decline in some ways at about the age of 35. However, we are making more important connections as we get older. And so it is true that as we get older, we do become wiser and we become more efficient. About 25% of people, give or take, when they're diagnosed with Parkinson's, have what's called mild cognitive impairment. What that is you can tell that the brain is not quite working the way that it used to. And if we were to do some testing, I kind of agree with that assessment. The brain is not quite working the way it should optimally. However, you can still get about your day pretty normally. You can make all your appointments. You're not going to forget those. You're not going to get lost driving around your neighborhood. You could be left alone for a week at a time and everything would be okay. But you can tell that you just can't do everything as quickly, as efficiently as before. The last part there is dementia. Some people will see the term major neurocognitive disorder. That is synonymous with dementia. I'll use the term dementia. And what we need to diagnose dementia is some of the same elements of MCI. So that's you think your brain's not quite working as well. We do some testing and we can say, yes, your brain's not quite working as well. The key difference, though, is that now it's starting to impact your life. You're not doing your bills. You're no longer taking care of the taxes. You've given up driving for one reason or another, not going to work. That's a big change in life. So that's dementia. The two other key components, though, is that we're not going to diagnose dementia if you're in the hospital and you're just coming out of surgery. If you've gotten a whole bunch of anesthesia, no one's brain is working right then. Okay, so this is something where you need to be otherwise relatively healthy and kind of in the clinic to make the diagnosis. And then the last point is mental health. So people who are severely depressed, bipolar, schizophrenic, if that is untreated, our brains are not working all that well. That also needs to be addressed before we formally diagnose with dementia. Now you'll see here that in general, the arrows are going to the right on a spectrum from normal to dementia. This is not true for everybody. So in longitudinal studies of large groups of people with Parkinson's, we know that about 80% of people are going to get dementia. So that's a large number, but it still means that 1 in 5 never will. Okay. The other thing to highlight is that there is a backwards arrow. Okay, so there is a small group of people in that MCI, that mild cognitive impairment group, that can actually shift back to normal cognition. It's not a huge group, but it does exist. And we'll talk about some of the strategies to kind of support that best we can at the end. So here, what are the domains of cognition, the brain? The brain's pretty complicated, but in general, we break it down into 5 different groups. Within each group there, you'll see a graph. The graph is showing in black people who don't have Parkinson's. And over the course of 10 years, how do each of those things change? And in blue, this is 150 people with Parkinson's that they followed every year for 10 years to see how is it that things change. So a few things show up then. So one in the top left, memory. Those parallel each other really nicely, which means there's no difference. This is a big difference between Alzheimer's disease, which is primarily a memory problem. Parkinson's memory is not as prominent an issue. The other thing that isn't so different is language. So being able to communicate and understand, that doesn't change so much between people with and without Parkinson's. Okay, so next is the executive function. So what does this mean? So this is all planning, this is goal setting, this is executing a task, this is being flexible, this is multitasking. Okay, so this is something that, so this is not, perhaps I could just tell you next when to advance, or does that work? Okay, could you go back to this one, the first one, back one more? Okay, thank you. Okay, so to give an example of this, what I want you to do out loud, if you want, is just to read the color of the words. Don't read the word itself, just read the color, okay? All right, so where were we? We had just finished our memory exercise. We have water, shy, and owl. 3 words, short words, but completely unrelated. So they might be hard to form connections in your brain, but we'll test that a little bit later. So next, the next is executive function. So we talked about executive function being planning and executing things to accomplish goals, being mentally flexible, multitasking. And so one example of this is a classic test called the Stroop test. And so what I'll ask you to do out loud, if you don't mind, just read the color of the words. Don't read the letters, read the color of the words. Oh, wow, so good. And next. Great. Okay, now do it again. Read the color of the word. So we were a perfect chorus to start. And this got really hard, okay? It got very hard. And the reason is that I've kind of given you different rules. Your brain has its own automatic path and it just wants to read the world. And when that's congruent with the color, that makes it pretty easy. But then the executive part of the brain has to stop and say, no, don't do that. We actually need to do something else. So there will be a necessary delay. That delay is normal. People with executive dysfunction or people with Parkinson's, they can have a greater delay than normal. So that gives us a clue that there's maybe some executive problems. There's one other test that I'd like to show you. I think I have to go back a couple. Okay. Yeah, let's do this. Okay, so here, this is a card sorting test. So what you're given is some stacks of cards. They've got shapes, colors, different numbers of them. And then what I'll do is give you a card. Next. No rules. I don't tell you anything. I just ask, you just need to match it up in the stack you think is correct. Next. So what you might do is say, okay, well, I see a red one. This is red. Let's do that. So you move it over here and I say, good. Next. All right. That must be the rule. Let's do that. Green, green. Next. Next. Good job. Now I give you another card. You say, okay, I'm crushing this. Next. Blue and blue. Next. You're wrong. I just changed the rules on you. You don't like that very much. Next. Now you have to come up with a new set of rules. Okay, it's no longer color. Next. Let's try number. Well done. People with executive function aren't as flexible. Executive dysfunction aren't as flexible as others. And that's a very difficult thing to kind of get out of that pattern. So another test to kind of bring that to light. Next. Okay. The third component, and this is some difference that we see in Parkinson's versus people without Parkinson's, is attention. Okay. What I'd like you to do is get your hands out, put it on the table. And every time I say the letter A, I want you to tap. Okay. So can you just do next like 11 times at a pace of 1 per second? Thank you. N, A, J, K, L, B, F, A. Okay, well done. The next component is language. And as I said before, language is generally preserved in people with Parkinson's. One way to do this is to just, vocabulary. And we can start with what we call high frequency words, words that you might encounter in everyday life or words you might use in regular conversation that you should be fairly familiar with. So we can say, okay, we got a tree, a watch, a broom, a coat hanger. Next. Then we can make this a little bit harder and bring out some words that, maybe you're not playing tennis every day. You probably don't walk your rhino in the park. And then in the top right, what is that? Maybe used that. I think it's an abacus, but it takes a long time. It's there, but it takes you a little bit longer. And so we can kind of get a sense of language function through this. Next. So what were those three? Oh, stop, go back. What were those 3 words we asked you to remember? So good. So those are unrelated words. And so it should be a little bit harder to try to remember them. For me, they were my son's first 3 words. So they have a little bit more meaning. But if there is some way to try to impose meaning on things you're trying to remember and group them, that can be helpful in trying to cue yourself to bring some things back. So if you bring verbal and the visual together, so your phone book in your phone, the contacts, instead of just the name, if you're able to put in a picture of their face and just try to link those together, that gives you 2 chances to remember instead of just 1. Next, please. So here, this is what I'm trying to simulate is some visual spatial problems. So take a look at this kind of Rorschach test almost. And what is it that you see? I heard a dog. Maybe a sidewalk. So next. Next, please. Great. So here's what the image should be. So people with Parkinson's, there's 2 components to vision. So one is the eyes themselves. Okay, so it's important that we check our eyes, make sure that we're wearing the right prescription lenses. But in general, that's not any worse than people without Parkinson's. The big problem is interpreting that information. And that's a brain thing. So here what we're trying to simulate is you might be able to see this is a dog and this is gray and this is green, but trying to put all of that together into a meaningful scene that can be a little bit more difficult. And so someone without visuospatial dysfunction will be able to readily see this is a nice Saturday afternoon park. Next. So with that in mind, so there's the processing that's happening at the brain, and there's another thing called contrast sensitivity, where we just lose the ability to see subtle changes in color, subtle tone changes. What sorts of strategies exist for us to try to help? So one, you might look in the bottom left and say, this is a nice, clean, modern, elegant white bathroom. I really like it. The problem is it's white on white on white on white. If I slip, where do I grab? If I'm trying to separate the shampoo from the conditioner, how can I tell the difference? So if you look to the right, one possible solution then is to color code and make them really stark. So you say, okay, the blue, that grab bar, that is safe, that is sturdy, I can grab that. The green, those are going to be soft things, okay? The towel is going to be green. The shower curtain is going to be green. Not something I want to use if I'm stumbling. You've got the shampoo and conditioner and soap. Those are all different colors as well, because you're probably not wearing your glasses here. And if things can kind of stand out, that makes things a little bit easier. In the top left, we've got a light switch. So at my house, I've got a white switch with a white backboard on a pretty white wall. That doesn't stick out all that well, but a fairly simple solution. And this does not require any electrical work at all. It's just to take that back panel off, put a dark color, and now it readily pops out. So you can readily identify where's the light switch on the wall. Some places in the outside world are thoughtfully designed, though not everything, but one is the escalator. So you've got a bright yellow line surrounding your step, so you know exactly where your foot should be, so you don't misplace it. Next. So what about wandering? And this can happen in dementia of any sort. The idea here is that you are somewhat propelled by your environment if you are confused. So here's an old video game. The character is standing in the center and looking around. Most of that is pretty uninteresting. You've got some trees on trees on trees. You've got two pathways. Maybe that's something that's worth checking out, but check out that cave. I want to go in there. That looks unique. And you kind of get drawn into it. Next. Well, again, what about the real world? Well, if you go to this is a library. Most of that is 90 degrees, straight lines, squares, pretty boring. No offense to libraries. But if you want to be drawn to the information center, who can help me? Well, let's change the structure there. So we can have the ceiling drop. We can use more curved lines. And so your eyes are naturally drawn to that point in the room, and then your body is naturally propelled there. So next. Next, thank you. So what about in the real world? So this could be your home or another environment. This is all pretty uninteresting. We've got some white walls, white ceiling, bland carpet. There's nothing really to look at except at the end of the hall, you see a door. You see a door knob that is black that stands out from the ground. That's what catches your eye. You know what doors do. You go through them. So you are kind of propelled and compelled to do that. Next. Another example, pretty uninteresting, except at the end, you want to go through those saloon doors because you know that they swing and that's fun and you're supposed to go through. You are pushed in that direction. Next. So what are some strategies to try to combat that without locking anybody in a room? So take advantage of what's kind of ingrained. So one is men historically for decades have been told, do not enter a women's restroom under any circumstance. And that might be enough. If you put a sign indicating that this is a women's bathroom, this is not going to be something that they're going to go into. Likewise, a stop sign. You don't even need to be able to read it. It's just a red octagon. That means stop. They're going to avoid it. On the left, you can see that the door is wide open, but if you were to close it on the far left, This is a clever piece of wallpaper that you can paste there, and it looks just like a bookcase. Bookcases are static. They shouldn't be moving. In general, there's not secret passageways behind it, and you're not going to try it, but you can still see that there's a door handle there, but it's hidden. And that might be something that does not work 100% of the time, but can be a safe kind of non-restraining sort of way to keep people comfortable in their home environment if wandering is an issue. Next. So what are some strategies then to try to support people with Parkinson's who have cognitive problems? So one is make sure you talk to your medical team, and this includes your neurologist and your primary care doctor. We know that about 1/3 of people with Parkinson's, if you look at their brain under the microscope, also have some changes that look like Alzheimer's disease. That sounds a little scary, but to me, that's a little encouraging because we have Alzheimer's medications that then might work. And so we've studied that, and that seems to be true. So there's a few: donepezil, rivastigmine, memantine, and they all work a little bit differently, but they can help with memory. They can help with apathy. They've also been studied to just show a general improvement in quality of life from both the person themselves and also the care partner. That may or may not be something that is right for people with cognitive dysfunction and is worth talking with your neurologist about. The second thing to involve your primary care doctor is to make sure that every medication that you're taking has a purpose, and we're not taking it unnecessarily or is causing just side effects and isn't helping. So one of these medications that is kind of notorious are a lot of bladder medications. They tend to work pretty well. In my personal experience, they kind of stop working or don't work as well, and they just end up with causing some cognitive problems. It may be worth trying to figure out re-challenging that. Maybe I'll stop it, or maybe I'll cut that in half and see if I can be a little bit clearer in my thinking, and that might be effective. The next thing is, in general, what's good for the heart is what's good for the brain. So don't smoke, get cholesterol under control, high blood pressure under control. If there's diabetes, get that under control, making the right healthy dietary choices. All of that plays into, not just the heart, but all of our blood vessels in the body, and that includes the brain. People who take care of those have better brain health and a slower rate of cognitive decline. So that's something that you can kind of take charge of now to help. The last thing that's worth mentioning is exercise. And this is where bringing in kind of another part of the team. So part of this can be with a physical therapist. So they can devise a home exercise program, what's right for you and your physical abilities. We know that any sort of exercise is good. They can also look at if they get to know you or if there is some cognitive testing. So if impulsiveness is a problem and what we call retropulsion, so a tendency to fall back, if that's an issue, there might be some visual cues that they can help you design in your kitchen, for example, so that you are essentially compelled to put your feet in a safe place so that when you're opening the fridge, you are not going to yank yourself back and fall down. You've got your feet placed in a way that is very stable for you. They can be helpful for that. But next slide. This is just to highlight one study, and they looked at people with Parkinson's only, and they just did two things: either do some stretching, do some mindfulness, do a little bit of cardio, or do just strength training. And the strength training was start with a little bit of weight, and every week we'll just add a little bit more, and we're just focusing on the major muscle groups. They were asked to do just twice a week. Okay, 30 minutes twice a week, and they were not allowed to do any more than that. This was pretty well funded. So for the first few months, they did have a personal trainer who could help them with that. But then for the next 18 months, they were told, all right, you've got all the tools, just keep it up on your own. Okay, so it's a pretty pragmatic, a pretty real world study, I think. And at the end, what they showed is that both groups, people were better off cognitively. than the people who did not do any exercise. Okay. And in particular, memory and executive function were better. So it's not so much, it's not so strenuous. I think the take home here is that doing exercise is something simple-ish that can be tailored to everybody's physical abilities. And that can be a pretty big payoff. Next. All right. And then the last thing before closing is so we've talked about your neurologist, your primary care, your physical therapist. Another potentially underutilized person is a speech language pathologist. So they are not just swallowing, but they are a big part of their work is communication. So some of that is if my voice is quiet, there can be strategies to augment that, to become a lot louder and communicate better. If there is stuttering, or if there's what's called palileia, where I just repeat myself and kind of echo myself, can we interrupt that and try to communicate my thoughts a little bit more clearly? So next slide. So one tip that I've learned, and this is something that we can all practice here, is put your finger up against the dot to the left and go back and forth saying one word. So you say, I hope you have a nice day. And you create your own metronome, and that somehow activates different circuitry in the brain and can kind of interrupt that process where you might be freezing or you might be echoing yourself. And it can be a way to circumvent that and get your thoughts across a little bit clearer. Next. So I think for the sake of time, this will be available to everybody. Some other tips that I've learned that the Parkinson's Foundation have put together to try to help with adjusting and supporting people with Parkinson's kind of throughout the disease, and that I hope you find helpful. Next. Okay, thank you. Oh, please, yeah, of course. We can leave it right there. Yeah. All right. So thank you, everyone. We'll leave this up for a little bit. And then after our next speaker, we'll come up and we'll answer questions if there are any. Okay, thanks.
Okay, for both our in-person and online audience, thank you so much for your patience with that AV. I'm not an AV expert, so I apologize. I think we've got ourselves on the right path. So thank you again. And thank you, Dr. Neilson, for your patience as well. Okay. I would like to introduce our next guest speaker, Dr. Louise Marasco. Dr. Marasco is a licensed clinical psychologist and is the founder of Transitions Professional Center. Her areas of specialties include palliative care, end-of-life care, and bereavement. She's also an assistant professor of medicine at OHSU School of Medicine. I want to remind you to keep those questions coming. We're going to have a Q&A after this talk. Welcome, Dr. Marasco.
Okay. So I have also been working with people with Parkinson's for about 12 years. Probably about 90% of my folks have Parkinson's or are a care provider, a caregiver or a care partner. So Parkinson's is very dear and near to my heart. So we're going to try this. We're all quite familiar, I think, at this point with problems with technology. So we understand, right? No, I pressed it once. I'm afraid to press it again. Oh, it did. Okay. Okay, so just really quickly, what are we hoping to talk about today? We're going to talk about role and identity changes in the context of care partner relationships and how that can lead to stress, and more importantly, what can we do with that stress? Stress is associated with lots of medical and mental health problems. And actually, as you'll see, maybe some positive things. We'll talk about effective coping strategies for care partner related stress to build resilience. And through the specific areas that I'm going to focus on are behavioral and cognitive interventions. So these are the kinds of things that I hear from care partners when they say, I'm stressed, and I'm stressed because they were the dominant one in the relationship. They did everything, and now I have to do it. Or, oops, I didn't touch anything. Or I never did the shopping and the cooking, and now I have to do everything, the planning, the shopping, the cooking. I have to take over the finances. I have to do the taxes. Taxes are a big, frightening thing for a lot of people. I already managed everything. Now I have to manage more. This is just the kind of thing that I hear from people. Identity changes. If you think about identity, we are grounded with our identity, who we are. We know ourselves as partner, as mom, as a provider of the household, of whatever it might be, whatever our career is. We identify ourselves in certain ways, and then that makes us feel grounded. Some of the kinds of identity changes people go through are spouse to caregiver, employee to retired, socially active person to isolated person. Pandemic certainly didn't help. Physically fit, I almost said to couch potato, but I didn't want to offend anyone. So physically fit to less physically fit. Active to fatigued. These are all things that make us feel like us. And when those things change, stress arises. So I think we can all agree that it's stressful. A lot of you might be retired, given your age group, and you might have been surprised by how, whether it was because of Parkinson's or not, by how hard that was. A lot of people are surprised by how stressful it is to retire because they've been looking forward to it for a long time. But once you get there, that identity shift is hard to adjust to. It's just an adjustment, a big one. So I actually kind of did need the computer in front of me, but that's okay. I said I didn't. So resilience. Resilience is what we want to focus on throughout the journey of Parkinson's, as somebody with Parkinson's, as a care provider as well. A care partner, rather. So to define it from the American Psychological Association, we have that it's a process and outcome of successfully adapting to different or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. A number of factors contribute to how well people adapt to adversities, predominantly among them, the ways in which individuals view and engage with the world, the availability and quality of social resources, and specific coping strategies. So we need these things in place for good resilience. Psychological research demonstrates that the resources and skills associated with more positive adaptation, greater resilience, that this can be cultivated and practiced. So we're going to work on building resilience. So one thing that's really important is that in the caregiver role, there are often benefits. First of all, the majority of caregivers that I hear from say, I want to do this. And they may want to do it more consciously or more subconsciously, but there is this I want to do this, or I'm committed to doing it. If you can focus on some of the things that provide you perceived benefits. In other words, I believe this is beneficial for me because our relationships is closer, or I feel appreciated more, or it's satisfying for me to know that my partner is receiving this care. They're loved, they're at home, etc. It's a feeling of accomplishment, perhaps, fulfillment, personal growth, and behavioral and cognitive abilities may get better. You may learn new things in the process. And so we know that caregivers that perceive benefits have a better mental and physical health outcome. So what are we saying here? Maybe just try and remember the positive things that you're getting out of it. I'm not trying to invalidate the challenging parts, but it might help to focus on the things that you're getting out of it as well. Okay, so now we're going to talk more about the challenging part, and largely stress. And all of these things below stress are intertwined. For example, financial problems, that can come from stress or financial problems can lead to stress. Health problems, they're all very intertwined. There's not necessarily cause and effect, right? So I'm going to talk a little bit about grief and pathology, and then we're going to talk more about stress. But I want to point out that one of the key things that helps people in the process of enduring stress is to control the controllables. Try to focus on the things that you can control. For example, let's say you get sick. Well, there's nothing you can do about the fact that you got COVID. You got COVID. So try to think about the things that you can control. Grief. A lot of these symptoms look a lot like depression. However, grief is a normal response to loss. And loss can be a job, a loss of ability to work, a loss of role, losing one role and gaining another. You're still losing a role. It's amazing to me how many people don't realize that you grieve when you lose things. Even your kids go off to college, or you move into a new house. It could be a great thing, but you're still losing something in the process. And the bigger the loss, the more grief you will have. So in Parkinson's, the care partner or the Parkinson's person with Parkinson's, it may be transient, so it may come and go, or it may be chronic. And so these kinds of symptoms of grief that can overlap with depression may be chronic. One thing that I like to say is when you're experiencing grief, think of it as a stress. It's a stressor on your body. So that means take care of your body. One more thing I want to say about grief before I move on. But I can't go back. That's okay. That there is no wrong or right way to grieve. And so if you have a family member who you feel like is not grieving, in other words, they're not crying, they're not talking about how hard it is, they are not expressing their sadness, that does not have to be. One does not have to express it. Some people are doing quite well with the way they are coping with their grief. And for others, it's quite important to express it. It might be to cry, to talk, to do artwork, whatever it might be. But there is no wrong or right way. The way that I often figure out whether somebody is missing something is I get to, how is the person feeling? Are they saying, I feel like I can't let it out, or I feel like if I start crying, I won't stop? or I feel like I'm crying all the time and I can't stop. They're telling me there's something not comfortable for them. Whereas if somebody says, I'm fine, I don't cry about it and I feel fine about it, it's okay. So what is the difference between grief and depression? That's a little bit tricky. And even some of our most astute providers are not used to picking out the difference. But ultimately, as I said, grief is very normal and it is a healthy response, whereas depression is pathological. And we need to treat depression. So given that it is so difficult to tease out these differences, and it really makes a huge difference to see somebody who's used to doing this, there are a couple things that stand out, which is hopelessness and suicidality. When people start talking about, I can't take it anymore, I'm thinking about ending my life, or I have no more hope, those are signs that likely there's some depression happening. If you're not sure where to go with that, I suggest talking to your PCP, let them know that you may be depressed. There is treatment for depression. So managing stress, there are two options. I love making things simple. There are two options for dealing with stress. Stop the stressors or improve your coping strategies. You may not be able to stop the stress. There may be just a lot going on at home, wherever, but you may be able to decrease some of it. Think about, some external things that you really don't have to be doing. Maybe I have one patient who says, I won't see my partner's family right now. It's too stressful right now. That's a great idea. That's an external way to slow down the stressors. You really don't need to have additional stressors when you're under stress. The other part is about improving effective coping. There's always room for improvement, right? So when I'm going to talk about effective coping strategies, so is this one effective? Having a glass of wine? Maybe. A glass of wine, I guess the AMA recommends 1 glass maximum a day for women, and I believe more recently for men too. It used to be 2 glasses, and I'm talking 4 to 6 ounces, not a whole huge glass. So keep that in mind. You're laughing. Is that good or bad? Okay, so we're not talking about this. This is not effective. And there's lots of other ineffective ways of coping. Sometimes we see some more risky behavior, getting out and doing things that are too risky, not effective. So these are ineffective ways. When we talk about effective, sometimes I have people come in to see me that are just completely overwhelmed, understandably. And the first thing we do is say, okay, let's get down to the basics, your basic needs. Obviously, shelter, nutrition. We'd be surprised how many people skip their nutrition. And, basic things. I would say that along with shelter and food and sleep is making sure that you're going to your own doctor visits. Don't forget about your own general checkups. In fact, you probably should go more when you're under stress to see your PCP and make sure everything is, like I said, it's hard on your body to be stressed. So check in with your PCP, do your regular annual exams. And then think about what's individual to you. For me, it's riding my bike. I have to ride my bike or I start to get a little crazy. Others, they need to pray to God or they need to do artwork. They need to be creative. In order for you to be the best care partner that you can be, think about what you need as an individual and try to stick to those things. So relaxation is a very effective coping strategy. There are many ways to do that. Oftentimes I do a guided imagery practice in a setting like this, but we have limited time. So I won't. But deep breathing, guided imagery, time in nature, time with pets, massage. This is a very, very excellent way of coping with stress. So again, simplicity. We're going to go to the thoughts. We either stop thoughts or we distract thoughts. And this is a way to cope with stress. Distraction, I'd say the most common things I hear from care partners is watching TV, playing games on their phone, reading. These are effective coping strategies. Some people tell me, well, I'm watching TV, I should be doing something else. Maybe, but this is an effective coping strategy. Distraction, you're not thinking about all the stressors that are going on. This is the other piece that I cannot recommend strongly enough. Now, it's not uncommon for this over 60 crowd to say, oh, I can't do meditation. It's not for me. But keep in mind, though there is kind of a lot of you were around in the 60s, there's a lot of negative connotation to meditation. And it's important for you to realize it doesn't have to look like this. All it really is stopping thinking. So you can do that in many, many, many different ways. Guided meditations are available on your apps, like Calm, Insight Timer are a couple of good ones. And then there's movement meditation like yoga or Tai Chi. There's other ways as well. But the point is stopping your thinking. Gives your brain a chance to rest. You don't even rest while you're sleeping. Your brain's still going. Your brain is processing. Mindfulness. So what is the difference? The way I think about this is that mindfulness is similar to meditation. It's stopping thinking about the things that are stressing you. It's stopping thinking, but you're doing something. So you might be doing the dishes or taking a shower or going for a walk. But ultimately, you're doing the same thing. You're stopping thinking. And how one does that in a very quick moment of explanation here is that they bring their attention to their senses. So if you're doing the dishes, for example, bring your senses to what you're doing. What does the dish feel like? What does the water feel like? What does the sponge feel like? What does my arm feel like moving? What do my feet feel like on the floor? What sounds am I hearing? So you bring your senses to what you're doing, and that helps stop your thinking and allow you to do a mindful activity. Jon Kabat-Zinn is the founder or the father, if you will, of mindfulness-based stress reduction. A lot of people benefit from this approach to coping, to improving even pathological responses to stress. He has a really great CD called Mindfulness for Beginners. I can't recommend it more. I've heard a lot of people say the book is a little repetitive and not quite as enjoyable, but the CD people seem to really like. And then Kimberly Carson, and this is all going to be at the end slide, and I think maybe it'll be passed out. But Kimberly Carson does a drop-in class called Breath by Breath. And she learned from Jon Kabat-Zinn. She at Duke University. She's really one of the best, and she does it MBSR courses at OHSU. But she's also doing Parkinson's specific for people with Parkinson's and partners class called Breath by Breath. So if you look up Kimberly Carson and Brian Grant Foundation, you'll find that information. So just to quickly run through what we said here. Identity change and role changes are stressful. Caregivers perceiving benefits have a better mental and physical health and they do continue performing their role better too. That's an important piece as well. Stress is associated with grief, pathology, health problems, social problems, financial problems. Remember to control the controllables. There's a lot of symptom overlap between grief and depression, yet one is a normal response to change, and the other is pathological. Sometimes it's not easy to distinguish. Effective coping with stress, don't forget your basic needs first, the behavioral interventions, and the cognitive interventions. A couple of resources I just mentioned. There's lots more, but if you start here, it's a pretty good place to start. And I can come back to this if I think this might be the last one. So I can leave that up there. And I'm sorry, I forgot to tell you guys to stand up and stretch. So please stand up and stretch.
The first question is for Dr. Neilson. What is the difference between delirium and dementia? And then the second part of that question was, can Parkinson's medications cause either?
Okay, a lot to unpack there. So dementia is a change in brain function that is impacting our daily lives in some way. Delirium is a little bit different. So the brain function is certainly impaired, but instead of being a somewhat static or maybe slowly progressive decline, delirium fluctuates quite a bit. So you can have very clear periods and very confused periods, oftentimes multiple times within the same day. There's also a lot more confusion around orientation. So where you are, when you are. And so people refer to sundowning. That might be a term that you've heard. The sun goes down, it gets dark. Now the world just looks like a casino. You have no cues whatsoever of what time it is and where you are, and that can be confusing. Delirium has got some sort of cause. So typically an infection, or it could be medication related. And if you're able to identify that and treat that, the delirium goes away. So then the second component then is about medications. Can medications cause, Parkinson's medication specifically, cause either delirium or dementia?
Correct.
So we don't think that any Parkinson's medications contribute to or accelerate dementia. Some medications may contribute to delirium. So we use so a lot of the dementia medications, they increase one of the neurotransmitters in the brain, one of the signaling molecules in the brain called acetylcholine. Sometimes we use acetylcholine blocking medications, so the opposite of that, and that can be particularly effective for tremor. So it's unsurprising then that those medications, things like Artane or Cogentin, can cause some confusion. Or amantadine is another medication that's typically used for dyskinesias that can also kind of cloud our thinking and create more of a delirium picture. Fortunately, though, reducing the medication or stopping it tends to resolve that process.
Got it. Thank you. So this next question, I'm going to start by saying that for me, one of the most distressing things that from my loved one with Parkinson's is when I see those cognitive changes. I mean, for me, that's distressing, more than tremor or other things like that. And judging by the questions, I think we have a lot of people that feel the same. So the question is, for both of you, when we bring these up with the doctor, how much should we be bringing up, and how do we bring it up? Because a lot of time our loved ones, they're not seeing maybe the same things that we're seeing. What's the best way to bring this up with the doctor if you're seeing something different than your loved one is seeing.
I'll start. So you're saying, if I understand correctly, that you notice that your loved one has cognitive problems or something's changed and you want to bring it up with the doctor. I usually recommend people bring it up with the person in the room. And I think oftentimes people with Parkinson's related cognitive issues, they do see it rather than somebody with, so the issues that we often see earlier on have to do with slowing processing speed often. And that, I think most people with Parkinson's see that rather than have somebody much farther down the line who has dementia possibly. So hopefully it's kind of earlier on when the topic comes up, and likely that person experiencing it is actually going to look forward to talking about it.
Bringing it up sooner than later. Right.
It's been my experience. Did you want to add to that?
Yeah, bringing it up soon is helpful, because then you're able to potentially quantify that or objectively capture that early on. And if we see a change later on, we can go back and say, okay, actually, things are okay. Memory is still doing well. Or, hey, this domain, we're seeing a big change here. Is there anything specific that we can fix now to try to help? I tried to emphasize, it might have gotten a little bit lost, the aspect of team and Parkinson's. And that's not just, the medical team and the PTs and the speech therapists, but that's you guys in the family. That's the team. And hopefully you're comfortable when the physician is asking, hey, what's the number one thing bothering you? That's a joint thing, because that's really important. A lot of things don't get mentioned, but they are the most distressing things. And that's the cognitive changes. And then hallucinations is another one. So I do try to make a point of explicitly asking that, but hopefully you're empowered to bring it up on your own.
Great. And we had a question from our online audience. I think this is for both of you as well, as I'm having trouble knowing how much to take over for my person with Parkinson's as they are having these changes. This person says they don't want to nag or cause resentment, but they're frustrated. So how do you know how much to take over? Where that boundary is? That's a tricky one, huh?
I think that issue comes up quite a bit in psychotherapy. So I can take a shot at that one. So I think that it's tricky because you don't want your loved one to be in danger or potentially not taking their medications accurately. So it's hard. It's a hard place to be. I think that, first measure risk. Is it risky? This person is not doing this correctly or accurately. And if it is a risk issue, then that's a good time to weigh more heavily on stepping in. If it's less risky, then it's the question's more up in the air. I think one of the most important things to remember is that a lot of what people don't like is the loss of control. And so what we see in the research is that when it comes to control, what matters is perceived control. And if you can really emphasize that while also maybe taking over some of the responsibilities, that may be helpful. You could also ask your doctor, is this something that is okay? Like, is it okay if they take their medications at the wrong time? If they're taking it half an hour later or miss a dose, is that a problem? So I guess that's my sort of initial answer. Right.
Yeah, and to add to that, you want to, as a care partner, to protect yourself to some extent from burnout. So, we heard that there's often this desire to help as much as possible. But particularly early on, maybe wait, have them come to you and ask for that help. And that gives them agency, so that they remain in control as much as possible. And then you're not stepping in unnecessarily. And that might change as the disease progresses. But hopefully early on, you can adopt that strategy.
Great, thank you. And then I think this is Dr. Neilson. This one was for you. You had a slide that mentioned 33% of people with the Parkinson's brain scan have it looks similar to Alzheimer's. Somebody wanted to revisit that slide and talk about what brain scan is that, and sort of what are you looking for that's similar there?
Yeah, let me clarify. So this is looking at the brain under the microscope. So this is at autopsy.
Okay.
These are not brain scans. Parkinson's disease has a particular microscopic signature, and Alzheimer's has its own signature that is unique and different. Interestingly, it seems that about 1/3 of people with Parkinson's have some of that Alzheimer's signature as well. It's a little bit unclear how meaningful that is, but part of that was some evidence to justify exploring Alzheimer's medications in a Parkinson's population where we may not have expected it to work. That's what I was trying to get at.
Great. Thank you for clarifying that. Okay. I have several questions here actually about apathy, and people saying, they try to get people out of the house or, more involved in their own care, and there's some apathy. How is apathy treated? Can we treat apathy? What should we do as caregivers?
Apathy is tough. So for those who don't know, so we heard a difference between grief and depression. Related but different is apathy. So they're not necessarily sad, even though their behaviors might make it look that way. They sit in their chair, they're watching TV, they're staring at a wall or out the window. That doesn't look normal. That's a different thing. But actually, they might be quite content. They just kind of don't have that motivation to get up and do much. That's apathy. And that's kind of a subtle distinction, but important. Two things with that. So one, medications may help. There's some varying degrees of evidence, but it's worth, if we know about, we can try to optimize the medications we're on to see if that helps. And the second is this is the one place where I give a prescription to nag, because if you do bother them and say, hey, I scheduled, we're going out for a walk, it's happening at 1 o'clock, and they get a few reminders and they get up and go. Once they get going, things are okay. And they will probably enjoy it and look forward to it again. But it's just really hard to make that first step. And you have to be a little bit comfortable nagging to some extent.
I can piggyback to that, because that is something that comes up in therapy also. The way I describe it to people is that it's like the ignition is broken. It's like that starter is broken. So somebody might say, I want to go ride my bike tomorrow. But then they get up in the morning and they're not going to ride their bike, and they can't be convinced to do what they said they wanted to do. So what I encourage people to do is the person with Parkinson's to say, I want to do X, Y, and Z. So they have the choice. They're saying, I want to go ride my bike tomorrow, but I know when I get there, I'm not going to want to do it. So if they're willing, and if the relationship is comfortable in this way, you could have the partner, as Dr. Neilson said, motivate the person to get out. So that person is being the ignition for the person with Parkinson's. So again, the person with Parkinson's agrees or says, this is what I want to do for myself. Because oftentimes they do want to intellectually want to do the things that they're not doing. and then have the person say, okay, I'm wanting my partner to be involved and be my ignition. Then they're like more part of it.
Mhm.
They're making the decision too about what they want.
Right. Thank you. I have several questions here as well about seeking outside help. People wanting to know, when should I seek it? What do I look for to know, hey, I need more help? And also, and then we had another question about that. What do I ask for when they're there? Is it medication timing? Is it, kind of things that people can ask for when they need outside help?
I think that's really individualistic.
Mm.
Did you want to? I mean, I think it depends on what's happening in the household. If you feel like your needs are not being met as a care partner, that's a good time to get some help in.
Mm-hmm.
I would go back to, am I getting my own needs met, whether that's basic or the next level? And then what kind of help? I think that depends on how things are going at home and what kind of things would be most acceptable for both of you.
And so to expand our team even further, this is potentially where a social worker can be really important. So most medical clinics should have a social worker associated with them, and they just have a different approach of trying to figure out, okay, what are the needs? What kind of hours does that break down into? What are your finances? And where can we kind of match up the services to try to help? I know the Parkinson's Resources of Oregon, they have their own social worker as well that can be reached out to. They're not going to be a long-term person, but if there is somebody that you need to talk to kind of get things started, to maybe investigate, because you just don't know who to even call about some of these things, that might be a good person to reach out to first.
That's great. And then I do want to sort of talk about that too. There's a lot of classes locally, exercise classes. There was a specific question, if the speakers know of anyone who teaches classes about organizing or remembering or prioritizing or those sorts of skills. Do we know of any of those?
So I mean, the first thing that pops into my head is Kimberly Berg's boxing classes, which people, I would say 99.9% love. Every once in a while, I hear someone who,
I'd say 100%.
Oh, yeah, it's pretty darn close. So I think that's a great opportunity for people, and you probably all already know about boxing. Are you talking about, I assume you're only talking about the person with Parkinson's?
No, I think it's for both.
Okay.
I think people just want to know what resources are available and what they should be seeking out. Probably exercise, as you said, the social worker, if there's any sort of, I know that's not a class, but somebody to sort of help guide that.
Yeah, I'm not too sure about that answer. Somebody who could help sort of point you in the right direction, but maybe the social worker would be a good person to ask about, and resources available.
Yeah, maybe we can share that in the chat if possible for Brian Grant Foundation and for PRO for locally.
Ah, great.
Wonderful.
So social work.
Yeah. For the online audience.
Everything.
Yeah. We have social workers in the crowd. Yeah.
Things like getting organized. So contacting them, looking beyond the community at resources for us.
Mm-hmm.
So just for the sake of the video, people who are attending, can you tell me who they should reach out to again? Area agency on Aging and Disabilities in Southwest Washington. And I don't either know about one in Oregon. Okay, so Google Area Agency on Aging. Okay. So they have respite programs too.
Right.
Excellent.
Yeah, seek that respite care to get the break, because there's a lot of agencies that will provide it at no cost or reduced cost, or that's
Including
thank
the
you.
VA, actually. I
And the
think they
VA.
do that sometimes, right?
Yeah.
Yeah, they have a respite program too for veterans.
That's great. Okay, well, that was the last question that I have for now. I would really excited to do our thank yous. We do also have a survey. I want to let the online audience know we have a survey that's going to pop up, and we also have a paper survey for everyone here. We want to hear your feedback, except about the AV. Pretend like that didn't happen. Evaluate everything else. We want to thank Dr. Lee Neilson. Thank you also for working through that glitch. Dr. Louise Marasco. And we want to thank our sponsors, Kiewit Kieran, Boston Scientific, AbbVie, and Accorda. And we also want to thank today's national presenting sponsor, Acadia. And Renetta would like to come up and say a few words. She's going to head up.
Good morning. Thank you so much, Sarah. For those of you who I have talked to, I will greet you again in the name of Acadia. My name is Renetta Mosley. I am the Advocacy and Industry Relations Liaison for the Western region. I come to you from St. Louis, Missouri, and so glad to be here with you. I know that you have enjoyed today and received a lot of information. I could tell that from the back. We are happy to be a part of the summits, care partner summits that are happening nationally across the country. And I am so glad to have been here with you today in Oregon. So thank you to the Parkinson's Foundation for partnering with us to be able to bring this day of learning and sharing today. So thank you very much.
Wonderful. Thank you to Acadia. Today's session has been recorded and will be archived on the Parkinson's Foundation YouTube channel within a few weeks. A link will be sent to you via email. If you did have a question today that was not answered, I know I always think of questions after the event. Please do reach out to us by calling 1-800-4PD-INFO or email us at helpline@parkinson.org. You can use that same contact information to order any of the free resources that you've heard about today, our book series, and our hospital safety kit. Many, many thanks to all of you for attending, learning, and participating with us today, and stay safe.